So very quickly, I'm just going to run through why we are talking about this issue. Essentially, a lot of these slides are taken from a study that we're taking, national study we're taking part in across the UK to monitor the surge, the expected surge in RSV. And the reason for this is that during lockdown in 2020, as we're all aware, we didn't really see children with coughs and colds, and RSV almost disappeared completely. We didn't see kids bronchiolitis children last year. However, so other countries that also went into lockdown and so forth noticed that they then had a peak and a higher peak of RSV, which was out of season. The most quoted is that happened in Western Australia, where they got more than double the usual peak of RSV, and that it affected older children as well, okay, which makes sort of biological sense because there are a lot of children who didn't get RSV when they should have done between the ages of 0 and 1, and so there was an older age group who are not immune to it, what we call an immunity debt that Mother Nature sort of needed to correct. Okay, and in Western Australia had this massive peak of children with RSV, but actually not all of them were RSV. There was also just a lot of coughs, colds, and wheeze. And for those of you at the moment seeing children and so forth, you're probably noticing that we're getting increasing number of ERTs. We had a big thing of croup about a month ago, which appears to have passed for now, but we're definitely seeing a lot of children with coughs, colds out of season. Now, this was also repeated in other countries across the world, as you can see from these graphs: Japan, the US, and even in Italy. Now, RSV cases have started to rise in England. This was from a report in June. We've had children with RSV coming through Frimley. We had our first sort of 28-day-old who was intubated who was RSV positive. So we know that it's here. We know that it is around, and we are expecting there to be this peak. So what we don't really know from all of this, though, is are we going to mirror Australia and the US or Japan? You know, is there going to be this massive peak in the summer? Or because everyone's on holiday and traveling around the UK and Europe, is that going to be sort of dissipated and we're going to have potentially a lower peak, but for longer? You know, is September, October going to be awful? We just don't know. Okay, it is very unclear, but we need to be having these conversations now, just so that everyone is aware. Okay, so then the next question is, what are we going to do about that? Okay, and that's where Alex and Reka are going to extrapolate further.
So, you know, if we do end up seeing as many cases as sort of the States and Australia, you know, it's a funnel. If secondary care are planning for a certain sort of percentage, then actually that's going to be mirrored in sort of primary care. And because it's a funnel, we're going to see, you know, an extrapolated sort of amount. So we need to find a way of getting patients to self-care because we just won't be able to cope, given what the current demand is, to see all the children and speak to all the children who've got a bit of a snuffly nose and have got a temperature but actually are otherwise well. So we've got to find a way of getting patients to self-care, and actually then when we see them, what do we do? Which ones need to be going to hospital? Which ones can care at home? So the Frimley Healthier Together platform is, you know, one of the things that we're using to try and help with that. So from, you know, the start, when you see on your triage lists, or whether it's sort of reception or the people looking at the e-consults, whoever, you know, every practice is different. So you have to find a way of how it works in your practice. So for example, in our practice, I've been, so when I look through the triage list as duty, I look through sort of the kids that have sort of got coughs and colds, a temperature, and what I've been doing is sending them an accurate. So for example, let's say they are, you know, 6 months old and have got a cough and a cold, you know, and the information seems they're otherwise sort of a well child. And what I'll do is I'll send them the accurates with the link of sort of the cough and cold, you know, and it's laid out in sort of a clear, you know, traffic lights and a traffic light So, you know, red, they need to go to A&E. Amber, actually, they need to speak to the GP, or actually they can self-care. You know, and if they're self-caring, you know, what do they expect from a viral illness? You know, not all children need antibiotics. You know, why do they not need antibiotics? And when I've been sending them the accurates with the ability to reply, you know, saying, actually, would you still like a GP appointment, or do you feel reassured? And as long as parents have that option of actually getting back and saying, no, actually, I still want to speak to someone, parents seem relatively quite happy. And I was surprised that quite a few have come back and said, actually, I feel pretty reassured. I don't need to speak to a GP. I just wanted to see, actually, do I need to speak to someone? And just looking through that information has reassured me sufficiently, which has been, you know, actually sort of quite a surprise and quite sort of positive. So let's say, you know, they say, actually, I do want to speak to someone. So you're doing, you know, your telephone triage. So we've got these remote pathways on the website, and there will be more coming up, sort of relevant ones. So, you know, fever, coughs and colds and over ones, under ones, because like Patrick said, we're going to see bronchiolitis, not just in the under ones, but the 1 to 2s as well, just because they've not been exposed to illnesses. So the one that's at the moment is sort of your cough and shortness of breath in under a 1. So, you know, your typical sort of bronchiolitis sort of child. So you can look at it, it's doing your remote sort of triage, your telephone triage, and decide, actually, this is a kid who is in green. I can send them the safety netting leaflet, and you can do that either by an accurates or using our SMS share page on the site. This is a child, actually, I need to be seeing in general practice. I need to see them in face-to-face because they're coming into the amber, or actually they're red, and I need to be sending them to ED. But it's got the paediatric advice line link there. So if you click on that, it's got all the contact details for the advice line, so that you can speak to, you know, unless it's an emergency and you've got, you know, a child who's having, for example, sort of an app, and you think, actually, I just need to call 999. But otherwise, it's calling the paediatric advice line, so you can discuss and see, actually, you know, to inform that actually this child is coming, and, you know, is it something that sort of paediatrics needs to be seeing. So you know, you've decided, actually, this is a child who needs to be seen sort of face to face. And we've got our pathways on the page as well. And like sort of Patrick said, it won't just be the bronchiolitis, it will be your viral induced sort of wheeze, you know, there'll be more sort of diarrhea, vomiting, there'll be other illnesses that we'll be seeing sort of quite a lot of, and that's all on the page, all the relevant sort of pathways. So the most relevant one for, you know, this webinar, sort of bronchiolitis. So it's very much laid out in the same way as is for parents. It's that consistency. We're all doing the same thing, you know, and, you know, Rachel will speak more about sort of the clinical side. But, you know, you've got your green, your amber, your red, and once again, those links to the safety netting leaflet, being able, you know, speaking to the paediatrician if they're, you know, an in-between, or, you know, they're red, and it's all integrated, so you can get those contact details in terms of going through the advice line, and just feeling confident when you're seeing the child, actually, this is a child who can manage at home. Do I need to run it by peds? You know, they've got a little bit of recession, but they're otherwise sort of well, they're not feeding sort of 100%, and you can run that by the paediatric advice line, just so that we're all helping each other out, both in the community and in secondary care, and just sort of that working together. In terms of, you know, how else can we use the website? So we're really keen for, you know, for practices to be promoting it, mainly because we want sort of parents to be thinking, right, I'm going to use this website to save myself a call to the GP, waiting sort of on the phone, or a 4-hour wait in ED, so that their first thing they're thinking of is, actually, I'll go and look at that website and see if I can manage it at home. You know, it's a bit like, you know, sort of face masks and, you know, bag for life for sort of, you know, in the supermarket. You know, initially we all just kept forgetting, and now it's just second nature, and it's trying to get parents to think first, you know, Frimley Healthier Together. So what we're sort of asking practices to do is, you know, thinking about sending, you know, your bulk sort of text messages sort of through MJOG or sort of iPlato, so that parents are aware of the website. So anyone who got someone in their household under the age of sort of 18, if you have on your practice homepage the Frimley Healthier Together logo with a link to the page, and from our Google Analytics, we can see that the practices that actually have that on their pages, we are getting quite a bit of traffic through. So suggesting that parents are using it in terms of going to their sort of practice homepage and going, oh, actually, I'll go and look at that. So, you know, it is working. And what I'll do sort of once I finish, I'll put a Google Drive document on the chat that's got sort of the logos, an example sort of MJOG message, and other sort of links. You know, other things, sort of putting posters in your waiting room, and you can contact me and we can send some across. When your nurses or yourself see them for, you know, our first IMS or 6-week check, we've got stickers that can just be stuck on top of the red book, sort of with the Frimley Healthy Together logo, the sort of QR code, the web link, and it's just getting parents to just think, right, I'll look on a, you know, on a site that, you know, it's been trusted, it's been recommended sort of by my GP, and I'll look at that first before, you know, e-consult sort of button, you know, telephone, turn out to ED. And if you're, for example, on the site and you want to share anything, there is that SMS share button, and you just put in the parent's mobile number and it will send them the link of whatever page you are currently on. So what I'm going to do is I'm going to pass on to Rekha Sanghavi.
So I think the Patrick and Alex have set the scene for what we're talking about. I just want to add that this what we're talking about is not a new condition. It's something that we have dealt with over the years. The treatment hasn't changed, the presentation hasn't changed. The reason we're talking about it is because we're expecting this unseasonal rise, and because we are perhaps predicting a larger than usual number of children being affected, and therefore, unless we plan, will be overwhelmed very quickly. The predictions that we have been given in order of priority are that it could be a 20 to 50% increase in cases of children, slightly older children, as Patrick said, with bronchiolitis, children with viral-induced wheeze. The next likelihood is that there will be no change, and the third likelihood is that we might see 100% increase. I think already, like Patrick said, we are seeing unseasonally children with respiratory viral infections, and I would say the ward has a significant number of inpatients with these conditions for this time of the year. So if we just go through some very basic information. So in primary care, what is it that we think you can do? I think it's important that these children have a face-to-face assessment before you decide the next step. That would include an overall assessment of checking the child over, eyeballing to assess for how sick or not they are, but looking in particular at the work of breathing, their feeding, the hydration status, auscultating the chest, obviously, and checking oxygen saturations. Referral threshold is if there's less than 92%, they should be put on additional oxygen. I know that some of you currently will not have oxygen saturation monitoring for children, but please may I recommend that you all contact your practice leads to ensure that you have this available in the practice so that you can check oxygen sats on children. I've just added a couple of extra points here to say that CREPS can often be heard with viral infections, so just the mere presence of CREPS does not suggest bacterial infection and therefore use of and therefore indication for antibiotics. Most pneumonia in children, as I'm sure you're aware, is not bacterial. Chest X-ray is often unnecessary, and we wouldn't routinely do a chest X-ray in hospital either. As you know, we would only X-ray if there was focal CREPS or persistent focal CREPS to make that diagnosis. Even those don't always need a chest X-ray. We would be make that diagnosis clinically. Ibuprofen and paracetamol can be used for febrile children. There's no role for steroids in bronchiolitis. Consider antibiotics only if you've got persistent pyrexia and persistent focal CREPS, like I said. And for older children with viral-induced wheeze, there is a it's worth trying a bronchodilator to see if there's any response, and if there is, then that can be continued. Okay, and the next slide. So I think the important message that I'd like to get out is that please refer directly to pediatrics once you've seen the patient. We do expect that you do a face-to-face consultation before you make that acute referral. I've put the numbers for the consultant hotlines. They are in operation between 9 o'clock in the morning to 6 p.m. Every day, Monday to Friday. After that, of course, there's the pediatric registrar via switchboard on call to take those acute referrals. The advantage is, we think, of offering this hotline service, which has been commissioned, is that we can have a meaningful conversation and offer advice at a more senior level, so that we can support you in looking after the children away from the hospital. Only children that are needing resuscitation should be directed to ED. Please, would you not ask patients to attend ED? Once you've seen the patient, there would be very few that you would need to call the ambulance for to send them to the ED directly. Even if you do end up sending a child to ED because you think their condition is life-threatening, then please call the pediatric number, as I've mentioned before, just so you can give us the heads up and we can expect to see the child in ED when they arrive. And the next slide. So once they get to us in hospital, what other treatment options do we have available? As you can see, very limited. So obviously we can provide oxygen, we can provide high flow nasal cannula oxygen, which is something that we use machines made by a company called Airvo. That's what we tend to use. We can provide feeding support by inserting a nasogastric tube. Very rarely we might need to use IV fluids. And of course, we can do some continuous monitoring, which is not available to you in primary care, but very few children need that. And it's for a short term, so that we can try and determine which way they're going to go. Bronchiolitis and viral illness are self-limiting conditions. The length of course is variable depending on what virus. Tends to get worse after 3 or 4 days and then tends to start getting better. So it's good to understand that, so that we can set the expectations of the family as to how long we expect the illness to last. And lastly, I've just added a list of resources available. There's plenty more out there. What resource you need depends on your experience and where you feel you need extra support from. So if it's clinical information, there's that available on assessment of a sick child. If you need further information about the data and the predictions for this respiratory surge that's being predicted, then there's links to some useful webinars that you can look out for. I thought the important thing today was also give you all an opportunity to ask questions. So that's the end of all our slides, and we're happy to take any questions. So I can see in the chat there was a question from Dr. Goel to say, do you need to check the viral status? And no, you don't need to in primary care. In fact, we don't necessarily do that in ED as well. We would only check a point of care test to, if we were about to admit them, just to help with cohorting more than anything else. So whatever the virus, the management does not change. We've talked about pediatric SATS monitors. I think there's some chat about that. How long would you consider persistent fever and persistent CREPS to give antibiotics? I think it depends on the overall condition of the child, the age of the child, the background, the past medical history of the child. But if you saw that there was relentless pyrexia, and when I say relentless 38.5 for more than a few days with focal CREPS that remain in that area, and the child is looking toxic, unwell, then it might be worth considering a course of oral antibiotics. But that's very rare. Often it's CREPS heard in one place, and then the next time you listen, it's somewhere else, and those would be likely to be a viral infection.
Dr. Ostel has asked a question, Rika. Are there any concerns of presentations mimicking COVID?
So over the last year and a bit, we have hardly seen any children symptomatic with COVID. What we have picked up is incidental findings. So if there is a prevalence of COVID in the community, there is COVID in the family, then of course, if you swab a child, they may be COVID positive. I really don't think we've seen any children, despite the fact that we have a large population around us, that have been symptomatic with COVID. There might have been one or two that we could have attributed their respiratory symptoms to their COVID. So I think I would always recommend use of appropriate PPE if you are seeing hot children, but what PPE you use in primary care is exactly what we use in secondary care. So literally that is what we use. And that's it, and good hand washing. And only if the child is on an aerosol generating procedure would we use airborne precautions. So the FFP3 mask and a fluid protection gown, depending on whether we need that, and gloves.
I'll probably just add to what Rekha said about all that. Look, I think we didn't see children, really, the young children with COVID that we know about. We saw children who had the now infamous COVID toes and these sort of chilblains to their fingers and so forth. Alex and I are grinning because we think our children probably had it, but we just didn't know what it was at the time. But we haven't seen children in this age group seriously unwell from it. What we have seen, and everyone gets very concerned about, is this Kawasaki-like illness in the more teenagers. But again, this typically, and the research shows us that that comes after a massive peak of COVID. So across the world, you had big peaks of COVID infections, and then you got a small group of teenagers generally who would get this sort of generally sick picture. And we had a few of those across our two sites, but really not that many. These children don't seem to really get that ill from it. Yes, they might carry it, but they don't seem to get ill from it.
Thank you, Patrick. Can I just, there's a question from Claire Linfield, which I think Alex probably needs to answer on Healthier Together.
So Claire, in terms of, so you've asked, is there Healthier Together request for early COVID testing? What do you mean? I don't know if you can unmute just in terms of explaining.
Sure, sorry, it was just that we have an awful lot of parents that are contacting us with kids with ERTIs, and nobody's accessed a COVID test for them as being a useful first test. So that's all I meant was, are they being asked to have a COVID test? Because everybody seems to be avoiding it.
So on our parent pages, it does have sort of the link to, we can possibly add it on sort of the the information. We do have, a link that says, in terms of sort of COVID, call the online sort of form in terms of accessing a test, if they've looked at it. So that is on the pages. We're also going to create something for nurseries, so that you don't get those sort of phone calls of, the nursery's not letting me bring them back until, they've seen a GP, just so that nurseries, can sort of understand firstly, and parents, lateral flow is not appropriate. It needs to be sort of a PCR. They need to access testing, and actually if it's negative and they're otherwise well child, they can return to nursery, they can return to school. They don't need to see a GP, they don't need to go to ED. So we do have something in place, and I can always look at the site and just make sure it's very clear in terms of testing.
Thank you, that would be great. The other thing that we've heard quite a lot of is that children who've been assessed at Frimley have then said, oh no, they told me I didn't need a COVID test, which is quite then difficult for us to turn around and say, hang on a minute, you really do. So it's more that that's at the forefront of people's minds still, and that everyone's giving the same advice.
Yeah, look, I think a lot of people a year ago would have been swabbing their children left, right and centre. I think everyone's got much more comfortable, if that's the right word, with COVID, and it is here to stay. And so I don't think parents like swabbing their children anymore, because, as I said, children don't really get ill from it. You can't necessarily blame them, but the government guidance is fever, cough, get a swab. But yes, but definitely Frimley Health does not advocate not swabbing your child.
Thank you.
Okay, and there's a question from Farad Darawala. We've heard rumours that pulse oximetry home pathways for children. I can imagine this could be operator dependent. Is there a plan for this? I can just fill in a little bit. So the early conversations we've been having in terms of managing the demand within the hospital, we're looking at, could we have some kind of outreach virtual ward for some children? Those children would remain under the care of the acute service, and they would be managed by the community children's nursing team from the hospital. But it's only a very small cohort of children. I'm not thinking about any kind of home monitoring system as we did with adults with COVID. We are not thinking about that for children. The only way we would be thinking about it is if we needed to increase our capacity on the ward, and we would do it safely and under the care of the paediatricians. Hope that answers that. Might we expect slightly older children with more severe RSV symptoms this year, as they wouldn't have been exposed in the last winter? It was, this is from Han Hoff. Rika, I guess the answer is yes.
Yes, that's exactly what we're expecting. And that is exactly right. Viral-induced V's, older children with bronchiolitis. Sometimes we do see nearly 2-year-olds with what sounds like bronchiolitis. But this year we're expecting to see more of those, for the reason that Patrick said earlier, is that they missed out last year, so they've got to build up their immunity by catching it this year.
Yeah, they're immune naive is how I describe them. So yeah. Any more questions, thoughts? I just want to make one final comment. If you, as general practitioners, require any help with Healthier Together, navigating the site, just any kind of help, get in touch, and we will endeavour to help you use it, because we think that that's going to be a fairly major linchpin in our management of the demand moving forward. And it's a very good site, and Alex and Zara have done an amazing job in localizing it. So we would like it to be used. How quickly do you get the RSV test back after admission? Recap. Final question.
It depends. So we do we have point of care testing, which can be back within a few hours. And usually, if we don't do a point of care and we've just sent a swab off, we get an answer within about 24 hours. There are times when, obviously, because of capacity, there might be a slight delay, but we have processes in place to make sure that we manage infection control in the meantime while the swab is pending.
Thank you, Rika. If there are no more thoughts and questions apart from the thank yous, yeah, it doesn't. Yeah, I think everybody's fairly happy with the content. Thank you all for attending. I hope you found it useful, and onwards and upwards, as they say. Thanks for your time, everybody. Bye-bye.
Bye.